142 on April 23rd. And we're gonna move into section 10 of S 126. And I thought it would be wise to perhaps have Ledge Council refresh us and do a walkthrough of section 10.
Great. Good afternoon, Jen Harvey from the Office of Legislative Counsel. I will put the language up on the screen. Be able to see. This is section 10, is on integration of healthcare data. This would add a new section to the subchapter in Title 18 that is on health information technology. And it would direct the Agency of Human Services to collaborate with the Health Information Exchange Steering Committee in the development of an integrated system of clinical and claims data in order to improve patient, provider, and payer access to relevant information and reduce administrative burdens on providers. It requires the agency's process to align with the statewide health information technology plan established pursuant to section 9351 of Title 18, utilize the expertise of the Health Information Exchange Steering Committee, incorporate appropriate privacy and security standards, determine how best to integrate clinical data, claims data, and data regarding social drivers of health and health-related social needs, ensure interoperability among contributing data sources and applications to enable a unified health data space that is usable by all stakeholders, identify the resources necessary to complete data linkages for clinical and research usage, establish a timeline for setup and access to the integrated system, develop and implement a system that ensures rapid access for patients, providers, and payers, and identify additional opportunities for future development, including incorporating new data types and larger populations. It requires health insurers, using our broad definition of health insurers, to provide clinical and claims data to the Agency of Human Services as directed by the agency in order to facilitate the integrated system of clinical and claims data as set forth in this section. And it requires the agency to provide access to data to state agencies and healthcare providers as needed to support the goals of the statewide healthcare delivery plan established pursuant to 9403 that we looked at yesterday. Once established, to the extent permitted by the data use agreements in place for each data set. And on or before January 15th annually, the Agency of Human Services would provide an update to this committee down the hall, and the Senate Health and Welfare Committee regarding the development and implementation of the integrated system of clinical and claims data in accordance with this.
Any questions for Jen on the language? Leslie.
So I understand that this is a new section, right?
New section.
I read here, new section in Title 18.
Yeah, it's a new section of statute.
So what's going on now? I'm just wondering, I see all this stuff happening, being introduced, but what is the current state of all of?
I think I'm going to let your next witnesses tell you what's going on currently.
Thank you, sorry.
Yes, no, it's okay.
But it is a new title, which means that there's nowhere, anywhere that these groups are directed to do anything. So that's what's new about it.
I mean, these groups exist. The Agency of Human Services exists. Health Information Exchange Steering Committee exists. Some integration is already happening, particularly through the Agency of Human Services and the Medicaid side. This is building on that and we do not currently have in statute an affirmative requirement to create and maintain an integrated clinical and claims database.
So that's the point. In statute.
Yes, I mean, and I think the other witnesses or some of the other witnesses will talk to you about what happens now, and some of that is happening because of statute, and some of that is happening because of their own initiatives in administering the programs that they administer.
Thank you.
At the risk of there are no dumb questions, this is a really dumb question. I'm going to ask it. Is there a definition of what we actually mean by integrated? I mean, what does that even mean, really?
No, we don't have specifically a definition. So this is, I mean, integration is sort of making things, combining things and having them work together, sort of fundamentally what I would say it means, but
Are we putting in here that we want one system? That we want everyone's system to be integrated together in an amalgam of one, or?
I don't think it necessarily specifies, I mean, it doesn't specify, for example, everybody uses the same electronic health records system, but more so that they would need to be interoperable.
Okay.
So that information sort of goes in and comes out in usable form by all players in the system.
Yeah. Great.
And, I think you'll hear from other witnesses, whether they think that's a good idea, whether they think it's doable, whether they think this is the right approach. So this is what is in the bill as it came to you from the Senate, and you may make changes.
Thank you. Thanks for refreshing us. Yeah. Okay. So, Will Dempsey, hi, how are you?
Good, how are you?
Good. Have you from AHS?
Yes, I am. Good afternoon, everyone. For the record, I'm Will Dempsey. I am the Health Data Officer for the Vermont Agency of Human Services. Pleasure to be here.
Nice to be here. Really curious about your thoughts on this, and you can go ahead.
Awesome. And feel free to interrupt with questions if you all have them, if the chair approves. So thank you again for having me. Just to orient everyone, I know this is section 10, but we're talking about section 10 here in S126. And I'm here to provide a little bit of clarity around the Agency of Human Services perspective and position section. I also know Blueprint for Health was invited to come in, and I'm going to speak for the whole agency, which includes Blueprint of Health today. So the Agency of Human Services, the Green Mountain Care Board, and the Office of the Healthcare Advocate have been collaborating on the Section 10 language. We're working on a memo right now to recommend some changes, and I think it should be coming out, I want to say, this week. So that way we've been working very closely on that together to make sure that we're all in alignment. Our goals are to ensure patient privacy, security, transparency, and have clarity around what the data can be used for from the system. To achieve these goals, AHS supports having the Health Information Exchange Steering Committee, which you saw referenced in the statute, involved in ensuring patient privacy, security, and transparency. The committee was established by 18 VSA 9351, so it's in statute, and maintains a cross-sectional membership of staff from the Agency of Human Services, including Central Office, Department of Vermont Health Access, and Vermont Department of Health, as well as members from the Office of the Healthcare Advocate, Bi-State Primary Care Association, Blue Cross Blue Shield of Vermont, the Vermont Healthcare Association, Vermont Association of Hospitals and Health Systems, Vermont Care Partners. We have a consumer representative, Vital, as well as the Agency of Digital Services, Blueprint for Health, and GMCB, among a few others. So we also post our full membership list for the HIE Steering Committee on our public-facing website, which is healthdata.vermont.gov, and it's under the Steering Committee tab. So as was mentioned, this work is building off the foundation of the Medicaid Data Warehouse and Analytics Solution, which we refer to as MDWAS in AHS. It's a large Medicaid modernization project that we've had going on for a few years. The good news is it's going very well. It will actually be going live at the end of this calendar year on schedule and on budget, which I'm pretty proud of, to be honest, as a member of the project team myself. And that will include linking Medicaid clinical and claims data. So that's kind of our foray into this is we're linking Medicaid clinical and claims because AHS has Medicaid claims data from our Medicaid Management Information System. And we're getting the clinical data from the Vermont Health Information Exchange for those Medicaid members. So we're using this project to link those and demonstrate the value of linking those records together. And I want to talk briefly about, even at a high level, about kind of the differences between clinical and claims data, because it gets very nuanced. So I'm going to try to keep it pretty high level and not get too far into the weeds. But clinical data, this is data that you would go into your provider, your doctor's office, and interact with them. We're talking about prescription diagnoses, test results, and treatments for ailments. And claims data is what services were provided and how much was billed for those services rendered. They're not the same thing. Alone, each offers a limited view. Clinical data doesn't include the cost associated with the services rendered, so you don't know how much you paid for whatever service was rendered. You also don't understand utilization patterns over time related to the claims that are being submitted by providers. For the for the linking of, sorry, I got thrown off there for a second.
So did I. So did we all.
Whereas, let me get back. The clinical data lacks cost and utilization. The claims data lacks clinical context. So all the notes and the details that your provider is saying, like, here was this person's blood pressure, here was this person's heart rate. All of those things are critical factors in your well-being. That's not included in claims data. It's how much did your provider bill for whatever procedures were performed. So by linking both of these together, we would be able to fully understand care delivery for those people, enabling better outcomes, assessment of better outcomes rather, identification of gaps in services and things like that, and improved care coordination for patients. And it's a foundation to really building value-based care, where we want to encourage high quality, low cost care and discourage low quality, high cost care. And ultimately, the goal is to do population health management and keep the total cost of care down. So AHS, oh, please.
I think I have a question.
Sure, please.
In my reading of this bill, the intention for this data and this integrated is only to improve patient, provider, payer access to relevant information and reduce administrative burden for providers. It's not a tool to be used in all the wonderful things that you just said.
Yeah, we would want to clarify that.
Okay.
Make sure that it's very clear what it would be used for. Right now, it's a bit broad, in my opinion and assessment, and we want to bring specific language that we're finalizing now. We don't have it done today. We worked really hard, I promise. We were all up late working on it. But it's not finalized as of right now.
Okay.
So go ahead. I just want to clarify.
Please.
What you're saying is you're going to offer updating on this language that we're looking at.
Yes.
Okay, so a lot? I mean, should we spend a lot of time on this? That's what I'm, but whatever.
No, not a lot, just clarification.
Okay.
Yeah.
Mari?
I have a kind of a broad
Please.
set of questions from a broad point of view. As someone who's used, and I'm going to speak specifically about electronic health records, which they're only part of what we're talking about now. For many years, and I've used different, from different companies, Epic being the one I'm most familiar with, but I've also used Cerner. And in the legislature, having followed along with, and before that, with Vital, I am a bit skeptical, knowing what I know about how difficult it is to achieve interoperability when you're considering proprietary issues between companies that own electronic health records. Then just the sheer numbers of different kinds of electronic health records when you add in clinics across the state and then Medicaid, Medicare, so public systems. I'm skeptical that we can get to a point where we would have true interoperability, understanding the like just the computer engineering aspects and everything else I've just mentioned, so that we have integration of healthcare data that is truly useful. Because it seems like we've been working on this for a long time in Vermont. And I don't think we've gotten there yet. And then there's also the part where I remember in another year, House Healthcare had many debates about opt-in or opt-out.
Yeah.
And that was a huge issue that seems like we'd have to get through that hurdle potentially as well, if we're opening up, even with tight privacy guidelines, for opening things up again.
Yeah, I can start with interoperability. If you don't mind.
Sure, however it makes sense to you.
Yeah, so the way that I view interoperability is like little I, big I. So big I interoperability is the 21st Century Cures Act. That's a federal law that requires that electronic health record vendors are interoperable with other electronic health records so they can share data between them. Not all of
How's that going?
Yeah.
it's a mixed bag. I will say vendors, most vendors are in compliance that I'm aware of, and there's a certification process that is required for the Office of the National Coordinator. They oversee health information technology for the federal government, and they have certified electronic health records that meet those specifications. They're also uncertified. It's not an official classification, but it's all the ones that are not certified. And those tend to be for smaller practices, more community-based organization type practices use those. But for providers that use incentive programs that the state has offered using federal dollars over the last 15 years or so, they were required by federal law to implement a certified electronic health record to be in compliance with the interoperability rules. It's not a perfect system, but
Data is being,
and that clinical data from those providers would go to the Vermont Health Information Exchange.
would or is.
It is, sorry,
Okay.
it is, yeah. And the Vermont Health Information Exchange collects that data from the participating providers that contribute data. They choose to participate. We don't force anyone to contribute data to the Vermont Health Information Exchange. That is what I refer to as big I interoperability. Interoperability in this sense, we talked a little bit with the Senate about this, is more like making sure that Medicaid data that we're getting can be combined and integrated with these other data. So it's not driven by federal law. Whereas it's more of it just makes the integration easier and more effective.
So that's a bureaucratic.
Yeah.
not a technical.
Yeah. I mean, it involves technical considerations, of course, but it's not driven by a federal law to meet like a very specific standard. Whereas the electronic health record vendors have to meet a specific standard to maintain their certification.
And the opt-in, opt-out
Mhm.
issue.
I mean, Vermont is an opt-out state for our health information exchange.
Covers everything now.
And that covers everything now. I think that was 2022 is when that was settled. And we would, that's what we would like to maintain from the Agency of Human Services perspective, of course, is maintaining being an opt-out state.
So it sounds like you're not as skeptical as I am.
I mean, there's work to do. Please don't get me wrong. There's a lot of work to do, but I'm confident that we can work through it, and we have attorneys that will make sure that we stay within bounds. And our first and foremost priority is patient privacy and security, and that will be what leads the way on any work that we do.
And then just to wrap it up, is part of what you're going to bring to us a guesstimate of whether or not AHS would need more funds to continue this work?
Yeah, as of right now, we're not asking for funding related to this section.
Thank you.
Of course.
I'm also curious about the opt-out piece, and can you speak to why you want it to be an opt-out? Is it specifically just for patient protection, or how do you expect sustainability in our health system if everyone isn't an equal participant in a shared data management setting?
So the opt-out consideration is related to clinical data with the Vermont Health Information Exchange. And if that data is if you opt out, if you go onto Vital's website or call and say, I would like to opt out, they have a process that they, as the operator of the Beehive, manage to handle those opt-out requests. And that data then wouldn't be sent along if you've been opted out, would be the goal.
Specific patient level data.
Yeah.
I'm sorry, were you done, Daisy? Or
Yeah,
did you want to complete?
go ahead.
It's not a provider opt-out, it's an individual.
Patient,
Okay,
yes.
okay. Thank you for clarifying.
Oh, Woody?
Yeah, I have a couple of questions. First paragraph says it's going to reduce administrative burdens to providers.
Mhm.
Is that going to reduce costs to our providers as well?
That ideally, yes. The goal is to always reduce administrative burden for providers, which I can't give you figures, obviously, but the goal would be by reducing administrative burden on providers, the costs associated with that administrative burden would be reduced.
Well, as you know, we're all concerned about healthcare
Yes,
costs today.
We are as well, yes.
And so I was hoping we'd get an idea how much we're going to save. The other issue is it has to be usable by all stakeholders.
Mhm.
How usable is it going to be? Are we going to require training for all the various data users?
So generally for large data systems, training is required before, just by the nature of the sheer scale, as well as the specific setup and configuration of the system. What AHS has been doing with MDWAS, the Medicaid Data Warehouse Project, is to make that training virtual and recorded as opposed to live and requiring resources to do. So kind of empower the user to learn how to use the system without requiring extensive training on the FTE side.
So not too great a cost. Yeah. And then extent permitted by the data use agreements in place for each data set
Mhm.
for the delivery plan. What are those agreements like?
Yeah, so these are standard agreements that are created between entities to share data. DUA, data use agreement. I've done several with different agencies and departments within state government. At HS, we have sort of a standard template that covers the high level legalese and requirements, and then it gets into like the specific data elements that are going to be shared, what they can be used for, what protections are required for those data elements. So it outlines like, when we give you this data, here's what you can use it for, and also here's what you're required to do with it, whether it's disposition at the end of it, like you need to destroy the data and provide certification of destruction is a very common requirement.
And it will be individual agreements or data agreements for the agency.
It would be at the
Agency.
agency level. Yeah,
Right.
yeah, yeah. Like
As it-
AHS and Green Mountain Care Board as an example. Yeah, from the entity to the other entity.
Thank you.
Of course.
I think Daisy had a follow-up.
I do. So you're not asking for any additional resources with respect to section 10, right?
Correct.
How many people do you have on your staff?
On my immediate staff, there are 5 of us, as well as 5 ADS staff that are assigned to my group.
I'm just wondering if you have any concerns about your team's ability to implement this. And given that in, section A, there may be some fiddling in order to optimize the capabilities, what you can actually do with this data set, right? There's a lot. And I tend to agree with you that that section could probably be updated a little bit. But I'm also just having had some experience with working with AHS over the years, as well as the data from AHS and making data requests of AHS. I haven't found that the data is always aligned or consistent with data that we get from other entities. And so can you assure us that you're going to have the resources that your team needs in order to get us data that is strong and accurate and can inform critical decisions in a timely manner?
So the data that we're talking about already exists. So it would be linking existing data, which is a lesser burden than creating a new system from the ground up to generate data. So my team would be focused on with our other partners, as well as Vital as the clinical, like the operator of the Vermont Health Information Exchange, who have the clinical data, and Green Mountain Care Board, who have claims data from BCures. So it would be taking those data sets and combining them. So I've talked extensively with my team about this. We have very strong, very well-educated, very experienced people, and we feel like we can do this work.
Lori, how will this reduce healthcare costs?
You're cutting right to the point, Larry. So the goal is to, as I mentioned, to reduce high cost, low value care and
Okay.
encourage high value, low cost care. But you can't measure what you can't see, and you can't do anything about something that you can't even measure. So the goal is to, by combining these data sets and being able to actually measure what's happening, we will be able to identify the problems and reduce those problems.
So can you give us an example?
Off the top of my head, an example would be if a certain patient has chronic conditions and they are seeing multiple providers, those providers could be potentially providing the same service redundantly. But we don't know what's being paid for those services. We only, on the HS side, we only know the clinical data that's in the VHI. Green Mountain Care Board would have the clinic or the claims data, potentially depending on factors that they have. So by combining those two, we get the full picture to be able to actually understand what's happening with those patients.
And then who would be, so that all makes sense, but then who would be analyzing the data to then alert people that changes need to happen so that costs can go down?
Yep.
That's still your team, or is that providers, or?
So it would be a few different folks. So my team would have access to the system. Green Mountain Care Board staff would also have access to the system. And then the stakeholders that we refer to in here would be a variety of different stakeholders that have a justification for having access to the system and a need for the data, and would need to get vetted and approved to have access, because
Okay.
of course we only want folks that need access to have access to any of the data.
Okay. And my last question, I apologize if you already answered this. How long do you think it will take for this to be accomplished?
Considering we haven't been able to start the work, because we're still talking about starting work, we're thinking 18 to 24 months.
Okay.
Yep.
I have Mari and then Leslie and Daisy. Did you?
No, I was just going to make the point that Lori and I are on the same track in terms of the analysis of the data.
Mari,
I think I'm good for now.
Leslie.
So what I heard you say is that it's coming from the patient perspective. Might you look at clinician data for overutilizers also?
I'm not sure what you mean. Sorry.
Might there be someone in your system who orders tests maybe that aren't needed? Let's say someone who has a people who have back problems, they want their MRI. They automatically get their MRI ordered. So that there's a clinician who ordinarily will over-order a test. Might you be able to look at data from that perspective
It would
as well?
depend on, sorry to interrupt. It would depend on our data use agreement with the Vermont Information Technology Leaders. Vital doesn't allow us to use the data for like investigations and things like that. I should be more specific. It doesn't allow us to go in and look for, hey, is there a problem? If we find out that there is a problem and there's some sort of fraud investigation from the Attorney General's office, that's a different
No, I'm not thinking about that. I'm looking at I'm thinking about patterns.
pattern.
Patterns of practice. That would this data help us direct towards patterns of practice of overutilization? Because
Sure.
that's what we're talking.
Yeah.
And is that something that you would use? Who would then, same idea, who then is in charge of looking at that and who is in charge of contacting clinicians? How does that all fit together as a whole?
Yeah, so that use case, we haven't gone the full length of it yet to understand like who would be the one doing the outreach to providers. But I would imagine that it would be someone in state government, most likely in the Agency of Human Services.
And,
Oh,
oh, I saw Daisy.
Oh, as a follow-up to Leslie's, a lot of, at least community mental health centers use a program called, SPQM, and they do, that's one major, driver for their practice improvement. They can do both, you know, by diagnosis code and then also, other clinical practice improvement initiatives with that. So I think it tends to be, what you're talking about tends to be more of a site-specific practice improvement thing, as well as from site to site and systems level.
Lori.
And this could be more for you, although I'd love your input. When we have the annual report coming back to us, wondering if we can provide language that you also report on healthcare cost savings. And since you're all working on new language, if you could think about how how we can put something in statute that you can report on that will show when and how we are saving. Would you think about
I'll take that back and we'll have to get back to you on that one.
that work for you, Chair?
Yes, please. I'm sitting here and I'm reading 18 VSA 9351, which is the Health Information Technology Plan that we currently have in statute. And I'm struck by this. The plan shall include standards and protocols designed to promote patient education, privacy, physician best practice, connectivity, blah, blah, blah. Overall, a more efficient and less costly means of delivering quality healthcare in Vermont. And I think I'm concerned that that may go in here and there's no actual real measurement of that. But anyways, I derailed you at the beginning of your testimony, so if you'd like to continue with other thoughts. that you have.
That is my full testimony.
Okay.
I want to give time to the Green Mountain Care Board and Office of the Healthcare Advocate as well.
Can we get it in writing? I think that you're gonna send language that collaboratively has been
Yes.
worked on with, and if you could include Representative Houghton's, if you all could discuss that around measurements of cost and hopeful savings, that would be great.
Thank you very much for your time.
Thank you. Thanks.
Good afternoon.
All right, Lindsay.
Hi.
Hi.
For the record, hi. My name is Lindsay Kill. I am the Deputy Director of Data and Analytics for the Green Mountain Care Board. Hi. Hi. I prepared a statement, so I'm going to read from that, but please also feel free to interrupt me with your questions. Good afternoon, Chair Black and the House Healthcare Committee. It's a privilege to be here today to discuss this crucial aspect of our healthcare data infrastructure on behalf of the Green Mountain Care Board regarding Senate Bill 126, Section 10. I am pleased to share that the GMCB, along with the Agency of Human Services and the Healthcare Advocate, have been working collaboratively to adjust the language in Section 10. Our aim here is twofold. First, to explore the potential for a more complete understanding of patient health records through an integrated claims and clinical data. And second, to ensure that this exploration is built on a foundation of robust patient privacy and security, transparency, and clarity regarding how this integrated data would be used. The GMCB is supportive of the Unified Health Data Space goals, and we are also committed to ensuring that this progress doesn't duplicate efforts or undermine existing statutes. We feel confident that the HIE Steering Committee will carefully consider the varied and complex issues that arise with health data integration. We trust that they will proceed with caution, keeping patient privacy and security as central to their aims. It's also important to note that if the Senate Bill 63 passes, the GMCB would have a voting representative on the HIE steering committee, further ensuring our perspective is included in these discussions. We are optimistic about the progress being made and look forward to continuing our collaborative work with the HCA and AHS to further improve upon the language in Section 10 and submit it to this committee as soon as possible. Thank you. That's the end of my slide.
Any questions for Lindsay? Yes.
I'm one of the neighbors in this committee. And I like listening to this. Why? Why do we have these analytics?
Mhm.
That's my question.
So specifically why do we have the analytics that currently exist?
Yes, and why do we want to improve? Just.
Yeah. So I think the easiest example to give you is to point you to Section 8, which you've already heard about.
Mhm.
Section 8 details, I think, 6 or 7 individual reports, that pieces of analytic work that need to go into the state health delivery plan. All of those, except one, the SHIP, which comes from VDH, all of those come from the Green Mountain Care Board, specifically from the existing all-payer claims database, or now from the Vermont Uniform Hospital Discharge Database, the VUDS data system. So when you ask why, what are we using this for? Well, we're about to use it in your state health delivery plan. As one example. As another example, the all-payer model. All of the analytics that power the all-payer model, save for the financial reconciliation for the ACOs, which came from CMS's ResDAC, their database. All of that came from VCures, the all-payer claims database. The reference-based pricing study that was submitted earlier this session, that came from VCures.
Okay.
Would you like more examples?
As someone who's new, I just
Yeah.
keep hearing all these studies, we're gonna do this, we're gonna integrate this, and then I just don't know why.
Good question.
Okay, Woody.
Suppose you have an example of the type of data that we can actually look at and see and understand.
Yep.
What it's all going to look like in the end. Is that too much to ask for at this point?
You mean you want to see like an example of what an integrated row of data from a claim versus a clinical record would look like? Or do you want a measure that can only be produced when you integrate claims and clinical data?
You're confusing.
Okay, I'll do the latter. So a great example, again, I'm going to point to the all-payer model. So the all-payer model, which we're currently still in, we're in extension year 2. The all-payer model requires a statewide directive health improvement plan, healthcare reform. From that statewide directive, we have individual goals at the state level. And then through those individual goals, there are agreements with the ACO to focus on certain measures that could be worked on to get to those overall goals. Will Dempsey in his testimony alluded to chronic conditions, a classic example of a measure from NCQA HEDIS measures, HEDIS, is the percent of plan members who are 18 to 75 years old with type 1 or type 2 diabetes whose HbA1c levels were within range. So you can have it be controlled or you can be in poor control. The plan members who have type 1 or type 2 diabetes claim. Whether or not their most recent HbA1c measure is in poor control or under control, clinical. This is a HEDIS measure that we've always approached through, we have individual sort of one-off agreements where we need to have linked data. I'll say like linked. I'm going to use what Will said, lowercase l linked data for these one-off analyses. It's usually through the Blueprint for Health. The Blueprint for Health is well known for doing this for their community health profiles. But with an integrated system, claims and clinical, we could just be measuring that statewide. Again, for everyone who's in both data sets, but we could just be monitoring type 1, the HEDIS measure for the percent of plan members with type 1, type 2 diabetes in for control or under control.
Maureen.
This is actually very exciting and I'm not so skeptical anymore. Considering I really love good data analysts.
That's me.
Do commercial providers, they're able to provide linked clinical and claims data, correct? They're
So-
technically able to.
Yeah, so we do have some limitations in VCures with the commercial data that we collect. We are limited to, we get like the mandatory submitted plans, I always say this backwards, it's the non-ERISA plans, submit to VCures, but we don't have the whole commercial market.
Yeah.
So if we had, for people who are covered by commercial insurance, who did not opt out of the, of Vital, of that data, if they were in the APCD and this moved forward and the HIE steering committee deemed it like, yes, let's go forward with this project, and it was eventually linked, then yes, we would have commercial clinical claims for the people in VCures.
And I may have missed something, but HEDIS, healthcare technology.
Oh, sorry, the HEDIS is actually, I should know this, it's the NCQA HEDIS. It's sort of like it's the peer-reviewed standard like metrics for monitoring, like again, the Blueprint for Health uses them. We use a lot of HEDIS measures in our all-payer model quality reporting. Some of them are tied to financial outcomes in these programs. So it's a peer-reviewed evidence-based.
National.
Yeah, national, yeah.
Thank you.
Yeah.
So so I can set in my mind where we are today. We have VCures. VCures houses claims data. Yeah, okay. So you've got a diagnosis code, you've got a procedure code. You can tell that somebody's had their hemoglobin A1C, but you can't tell what the hemoglobin A1C value is.
Correct.
Okay, you also know how much bill amount was. And you also know how much was reimbursed, what the allowed amount was. Okay. So then we have Vital, and Vital is collecting from selected providers who have opted to share data. They're getting the clinical data. So they've got the hemoglobin A1C result. And VCures has that there was one. So far, we've been talking about collecting this data and the value of collecting the data. But in my mind, what I was thinking that this was moving towards was, to the cost savings. What we really want is we want to ensure that it is accessible for that provider who has that patient in front of them to say, they just had their hemoglobin A1C done last week. Here was the result of it. I'm not going to order another one. And I'm not seeing anything in this. I'm seeing a lot of people within organizations and state governments who do a lot of the data collection, but I'm not seeing this focused on what are we building for the provider, because ultimately that's, just taking another measure. I mean, I don't want to sound cynical or anything.
That's okay.
But another program developed so that we can measure things and then not do anything with the actual measurements. I'm not sure I'm interested in that, or I'm not sure I see the value of that anymore.
Yeah, so, okay.
I'm looking for something that will make it easier for the provider to have accessible information regarding the patient that is right in front of them. The classic car accident in Rutland when you live in St. Johnsbury. And that provider at Rutland Regional will have instantaneous access to the health data. They will know what medications that person is on. They will know what their problem list is. They will know that they're on an anticoagulant. So that's what I'm hoping we can build here. And how do we build that? And what language do we do to get something forward that can happen instead of just measuring quality or lack of quality?
So I have an answer for you. It's okay. So there are, to my knowledge, 2 other states that have, maybe 3, that have an integrated all-payer claims database with an HIE. One of those states, New York, has a real-time APCD. And I just want to clarify that an APCD being claims data, claims will not come from the insurer until they've adjudicated. So from my time working for Medicaid, adjudication takes like a week, 2. So the best lag time that I know of is direct Medicaid feed, and that's a week to 2 weeks. I'm sure someone from Gainwell or the MMIS could correct me. If it's faster now, great, but that's what it was a couple years ago. Speaking to the topic of savings, New York State's real-time APCD costs more in a month, almost, than our entire 5-year contract for our APCD, the current one that we have now. So if the goal, I'm not qualified to speak on what the goals are or should be. I'm just letting you know. If the goal is a real-time claims feed for providers, that is not what we currently have in the APCD and has a very different price point than what we currently pay for. So I just want to say that. In terms of that, I can't speak to the clinical side of things, like how fast are clinical data available, prescription. I heard you mention prescription data, or, this accident in one place when somebody really lives from another, and they need they need those 2 sources to talk to each other. Claims wouldn't be your vehicle for that anyway. So that's what I'll say about that particular goal that you just outlined.
Woody, did you have a question?
I did, but I forgot what it was.
Sorry.
That's quite all right.
Will, did you want to?
For the record, Will Dempsey, Jeff, sorry, I'm fine. I can speak a little bit to the clinical portion of that if you'd like. So part of this, Rebound Care Board has their lane with the claims and AHS has our lanes with the clinical. So what we're trying to do is work better together and share the data between us that we each have for our very specific lanes. On the clinical side, the Vermont Health Information Exchange from participating providers, we call it real or near real time. So a lot of it depends on the speed of light with the internet. As we all know, sometimes the internet's fast, sometimes the internet's slow. But when a provider is contributing data to the VHI, including their problems and as well as their prescriptions and their diagnoses, when they're entering it into their EHR, depending on their settings, that's going up to the VHI. And it's near real time. So we're talking minutes, not hours, not days. And providers at the point of care have access to our provider portal where they can log in, say someone comes into UVM Health or the UVM main campus and the person's unconscious, they have no ID, or maybe ideally they would have ID. They can look that person up and do what's called breaking the glass, where they can't collect consent from the patient because they're incapacitated, but if the person is conscious and able to give consent, then the clinician can say, can I look up your medical record in the HIE and see what allergies you have? And then they can get that affirmative consent and go look them up in the provider portal. So that functionality exists today. on the data side.
So I'm trying to figure out how this helps providers. And how does this control costs? I. I guess that's what I'm trying to figure out, or is this just a fancier way for us to have more data? Would you like to weigh in also?
Diane, right, for Green Mountain Care Board, I just wanted to be clear that having been around this bill for a little bit in the building, I would say that AHS or the Green Mountain Care Board, this was not something we wrote or committed, we're reacting to it. So, we're happy to react to it and take your concerns back and author of the language is helpful.
Woody?
Yes, I
You
remember.
remember?
Yes, I did. Are you working with the individuals that are going to be using this data? To see, or will you be working with them in the future to ensure that they can use the data, that is friendly to them?
Yeah.
That sort of thing.
When you say individuals, could you please be more specific about who you mean?
Well, whether it's a Green Mountain Care Board or whether it's a provider.
Okay.
Do you have, as you create this system, are you looking to them to test drive it?
Yeah.
To make tweaks as you go along?
Yeah. That is a great question. Thank you. I think what I am hearing is a lot of interest in what in the industry we would call it's called an analytic layer. So there's data underneath, and then there's like a portal, like what Will is talking about, that providers can log into and get real-time feedback about either the individual that they want to see or their caseload or anything like that. If I am correctly hearing that, the examples that I know from my time in state government that have accomplished anything close to that with an integrated data source are OneCare Vermont with their I want to say like collection of practices, and that those interventions being tied to like financial incentives and all that. And then the Blueprint for Health has a very robust practice and provider network with a portal where this data is integrated, and they can get, as far as I understood it, pretty close to real-time feedback. And Blueprint for Health being Medicaid data being with like a week or two lag, it was possible to do that. I'm not familiar with any state who has been able to stand up the level of technology of an entire statewide real-time or near real-time provider accessible with an analytic layer to help them with their practice intervention type of technology. I think that would be a different, that would be like a different level of infrastructure and investment than what is currently written here.
That doesn't seem right to me.
Okay.
If we're creating something, we should be able
Yeah.
to have it for everyone.
Yeah.
To look at.
For
the
providers.
For what they want, and they should be providing, everybody that's using this system eventually should be providing you input. Geez, that's really neat. But we could add this or what have, it seems we want user input on all.
Oh,
And
yes, for sure. Whatever direction this would go, we would be working with those stakeholder groups. I just meant to say that that level of infrastructure, again, going back to this example with New York State, if you would like real-time or very close to real-time integrated claims and clinical, that there's only one state doing it, it's New York State, that cost is more than our entire, like our whole
you don't
APC
have the
contract
money.
right now. So like, I'm, like Diane mentioned, like happy to take that back and talk to the rest of, talk to our people about that. Yeah, no, I will. I'll put my name on it. Yeah, I'll put the data analyst stamp on it. Yeah.
Mari and then Wendy. Yeah. Easy.
Thanks, Mari.
Do you think the success that you mentioned of OneCare had anything to do with, did Epic play a prominent role in that because of a large number of healthcare entities were using that system? And saying that, just, I know we're not headed in this direction, and I'm honestly not testifying to support monopolization of any part of our healthcare system, but
Yeah.
I do believe if we used one system,
Mhm.
I'm partial to Epic, but if we used one system
Yeah.
throughout the state, that would make
Yeah.
things so much easier.
That's a really good question. I don't think that I don't think I can answer that. That might be more of a OneCare question or, yeah. But I do think it's a really important question to ask, like what helped contribute to the success of that real-time feedback for providers?
Wendy.
I'm just curious, like you say New York who's using that information?
I do not know the answer to that question.
Like, I just like, this
Yeah.
feels like we're reinventing the wheel, like we have a database here, we have a database here. I'm
Yeah.
like with Mari, like Epic.
Yeah.
Just seems like everyone can use that. You can get the analytics from that too, correct? Like,
Yeah.
okay, I'm sorry. I just don't understand this at all. Sorry.
I could make a comment, but, well, I think Daisy has a question.
I think there are more organizations and maybe they're not as, or more entities, that states, I mean, not entities, that are doing, statewide pooling of cost and clinical information.
Mhm.
Maybe they're not as, multi-provider type or something as New York, I'm not sure, but, Kansas, Georgia, Minnesota, Arkansas. There's at least 5 states that are doing it, with mental health providers and, managed care organizations, substance use, IDD, and trade associations and state departments of human services. And, I'm going to send information to Diane, so we can look at some case studies and what they've done, but it's pretty powerful in terms of both looking at clinical outcomes and then across their systems. But I think there are other states that are doing it, but New York is specifically getting the at a glance, and these are maybe updated like once a month because they're going through a third party to manage the system.
Yeah, New York's again, if I wasn't specific before, New York is the state that is doing a real-time APCD integrated with a real-time EPI. That is my understanding of what they're doing. So it may be different from what these other states that you're persistent doing. So yeah, we will take a look at those and
Okay. Oh, you wanted to make a
I
comment?
want to make a comment about Epic. As someone who works intimately with Epic,
Mhm.
Epic is designed for large systems, UVM, Dartmouth. It's really out of reach for small places, Brattleboro or, Grace Cottage. It's out of reach. So
So who would use this? How would like a small hospital use this system?
that's a great question, which I don't know the answer to.
Okay.
That's what we need to
I
know that.
don't feel like you can glean anything that would be productive to a hospital or I'm sorry.
It's just that we talk a lot about Epic as sort of a
Yeah.
behavior.
Yeah.
It's not
for everyone.
applicable. Yeah, it's not applicable in every setting,
And I
even though
think
we'd like it to be.
And I think we heard testimony this morning from a couple hospitals who had some challenges. Yes, when implementing a new electronic health record, it is
Fortune.
Absolutely.
We all went through that. It just goes with it. And I disagree. I think Epic has the capacity to fit the needs, and they've shown within a large institution how they can scale down their focus to a particular clinical focus. So we're not.
We're not arguing about
using
Epic, but just so you
Epic, but-
understand that Epic,
Yeah.
it doesn't really work everywhere.
No,
Even though
I-
we wish we could have one system, that it would take a lot of work to get there.
But it
No.
could.
But if we're looking to cut costs in our healthcare system, and I think others have talked about it, administrative issues like Epic would be one way to maybe reduce those healthcare costs.
But look how much money they lost trying to implement what they were trying to implement, which they never mentioned, which was fine, but it's big. It's way big.
You're not talking about one system. In the very beginning of this, that was the goal, to have one system. That, with the hospitals and others saying, no, we don't want that, because there were other systems that were cheaper, et cetera. And Vital was supposed to be the hub of these systems. So that if you had a small system and it wasn't Epic or whatever system, they would be able to interpret that and then spit it out so that in Central Vermont, you could get the information you needed on a patient there, or you can get the information at Dartmouth. So I don't know what the hell happened with Vital and why that didn't all happen,
Well,
but
We're gonna have Vital on. Vital's with us today.
Yeah.
I, to
you
that
know, we just
point
spent a
though,
half an hour talking about systems integrated. And that was supposed to have been done years ago.
well, I wanted to ask Will, and this is the last question. Minus all of this language here, and you indicated that AHS was prepared to do this, no required funds. Is there anything currently that precludes you from just doing this anyways?
Not to my knowledge, no.
Okay. Thank you. Thank you, Lindsay.
Yeah, thank you.
I told you, I'm loving that we're having people in from the board. It's everybody coming in from the board.
You should ask that question like at the beginning.
Oh, yes.
Would have saved us a lot of time.
What's the value of having this then?
Sam.
Yeah.
Welcome.
Thank you.
Right?
I'm not Mike Fisher. Sam Peisch with the Healthcare Advocate. This is a great day. I feel like the data nerds are kind of uniting.
You said that, not me.
Yeah. And also I'll have Eric introduce himself.
Hi, Eric.
Hi, so my name is Eric Schulteis. I'm a staff attorney with the HCA. Thank you.
Awesome. So Eric's the real expert. So I'll just do some high level comments. So I previously testified in the Senate and Senate Health and Welfare on this bill, and on Section 10, we did have some concerns about the language in this section being too broad and kind of getting ahead of ourselves about what we could do. So as Will and Lindsay mentioned, I think we're very close to a consensus on language that really puts the best practices for patient safety and data sharing at the forefront. I think we're all in agreement on that. I do also want to name that I think the healthy skepticism that I'm reading in this room about different data integration efforts, like, is it worth the cost? Like, I think that's really good. And I support, I think, Rep. Hoden, you mentioned a call for specific measurement and accounting of costs. I mean, that's music to Eric and I's ears. I mean, we love measurement. I mean, measurement is but one thing. You need to act on the measurement as well. And I think we've all been a part of reports that, don't always get acted upon. But I think we support that, putting that in some kind of language. It shouldn't surprise all of you that we hold the view that you need to look at the evidence for a specific application before you implement it. So I think you'll see that in the consensus language that will come to you probably later this week. And, since we testified in Senate Health and Welfare, that was, it feels like a year ago, even though it was only a month ago. I think with everything that's going around in the world, I'll just speak vaguely about that. there are real concerns about data and protection of data, so we wanted to put that at the forefront of the consensus language. So you'll see that when we present it. I will say just about costs, I completely agree that we need an accounting of, how expensive things are. Is the return on investment worth it? That is but one lens to look at. Some things cost money and they are beneficial to patients and providers. So I just would note that, that's not the only thing we want to be thinking about. I know no one's saying that, but I just wanted to name that. So I think I'll turn to Eric, since he knows probably 100 times more about this data stuff than I do, to see if he has anything he wants to add or correct of what I said.
Thanks, Sam. So just because I think it may be relevant to this discussion, I spent about, I guess, I've been at the HCA for about 7 years, so just a few months shorter than Mike. Before this, I was doing research for about 7 years on the use of administrative data for policy and planning, for parties like a housing agency, the DoD, Department of Veterans Services. I mean, so I'm happy to give you examples from projects that I ran. I think as we start out, it's the consensus language puts what we feel are appropriate checks on the integration of data so that we're following best practices where the evidence leads us. So right now, we don't honestly know if claims data can be used for clinical purposes. We just don't know. And I think that's why AHS is conducting this test with the Medicaid population. They already have that claims data to see if it can work. And I think what's going to happen is we want to have a committee look at that and say, hey, is this safe? Can this be beneficial to Vermonters? And clinicians, because we don't want to jump into a scenario where we say, hey, integrate at will. But we also don't want to take off the table something that can benefit Vermonters. As we think about these different data systems, I think it's important to keep in mind that we have EHRs, so the clinical records that your provider sees, and then Vital does the clicking through to see what happened at Rutland Hospital if you go to UVM. And then we have VCures, which is predominantly a research database. And the state uses it for policy and planning purposes too. So these are two fundamentally different things, right? It's not a duplication. They serve very different purposes. And I think what this bill is trying to get us at is to figure out where we can find appropriate synergies between these two database systems, right? Between the clinical and the claims, and maybe other public health data like social determinants of health. This really isn't about, say, Epic for All, which is a dangerous subject to get me on. Or OneCare, that's also a dangerous subject to get me on talking about. But I think this is a good step. And I think what you'll see later on in the week, the consensus language, at least for me, hits on a lot of the concerns about ensuring patient safety, ensuring this is done safely, and also done in a way that can respond to the conditions in the world. Because we definitely don't want to make things riskier for Vermonters, given the current environment. And right now we're 90% of the way there towards consensus language, maybe even 99%. We're waiting for the proverbial lawyers to sign off. And I imagine everyone on the committee knows how that works. So
Don't come back with the words inarticulatable.
Yeah. My other
Or nexus.
yeah, we're not going to come that word. That word we Mike said, do not use that word, and I still did anyway. And I'm so sorry. I take full responsibility for that word choice.
Oh my gosh, you were one of those lawyers.
Yeah, I'm one of those lawyers. I'm a reluctant lawyer, right? Like I practice law. I practiced law in California at Legal Services, and then left law to pursue another graduate degree. And so I really don't. I just pretend to be a lawyer for like a few months during rate review, insurance rate review, and I'm reformed, is what I should say. I'm a reformed lawyer.
Oh, any questions for Eric or Sam? Sorry.
Do you feel that the language in this bill and or existing law provides the Office of the Health Advocate enough input and engagement in section 10, or would you need more language to make sure that the office was actively involved in what section 10 eventually will be?
Yeah, so that's a really good question, Representative Cordes. I think, the consensus language, we have more power to the steering committee, and to integrate a specific piece of data, you have to get a majority of the committee's vote to yay. And that's not just a majority of the quorum, but an actual true majority. And we are named as a voting member. And so I think that both puts a check on what AHS can use, but also, and puts us at the table, but also doesn't make it so hard that if a good use is found, if something can be proven up, that we take a potential benefit to Vermonters off the table. And I would say, people change, but in my experience in Vermont and looking who's on that steering committee, it's a committee made up of data nerds, to be frank with you. And so, it's not like I don't think we're gung-ho futurists, like big data is always great. We're also not like data is always evil. Those are different sides of the same coin, in my opinion. So I think we want to do things carefully and that are proven to be, that as best we can prove, as best we can know, will be beneficial to Vermonters, and have checks and balances in place. So if it turns out we were wrong, or the committee was wrong, that we can walk that back as quickly as possible.
I see Lori has a
Thank you.
question. I have a quick question, just because I have the Office of the Healthcare Advocate in front of me. Even with the consensus language, the 99% completed consensus language, I'm wondering if section 10, if it helps Vermonters, and in the opinion of the Office of the Healthcare Advocate, is it something on behalf of Vermonters, or is it something on behalf of the data nerds? No offense, Phil, I'm so sorry. That we do.
Yeah, I think, and Eric, feel free to correct me on this. My read of it is to explore the possibility of it being beneficial. I think it could be beneficial. I don't think we have enough information to know if it is or not. And I think we don't want to close the door on the possibility that this could really help people. And I think we also have to be, this is something that I say a lot, we also have to admit when it doesn't work. And I'm not a member of the steering committee, but I trust that the members would look at that in an honest way. Because I don't think any member of the steering committee wants to waste money in a way that's not helping Vermonters. And I think the language before you does, or that will be before you, does a good job of creating that, exploring that possibility. So I personally can't say for sure we know it's going to benefit, but if we don't have language in there, I think we might be closing the door to that possibility, is my fear. Do you want to add anything to that, Eric?
Yeah, just that, and I know this is all hypothetical, make-believe language that the committee hasn't seen, but I think we unambiguously support the consensus language. And I do believe it's the right mix of caution and also recognizing that this is a bit of we're at the frontiers of usage and we have to be somewhat bold, but also because it's people's health, we have to be very cautious. And I do feel like there is a real potential, and I don't, I think, at least, from what I know of the people who are here, who've testified before the committee and the other, so it's a relatively small community in Vermont of kind of data people, is that, there is, it's not data for analysis for analysis' own sake, that it has to produce some value. And I think it's not, it's data nerds to the extent that like people understand data, that we're not tech optimists. But I think I think all the parties want a benefit that actually accrues to Vermonters.
Lori?
So the pilot that's already being done, linking Medicaid data with clinical data, if I have that right, won't that give you an idea of whether or not this will work? And shouldn't we look at that first before we dive into more?
So, at least from my perspective, and Will's might have a different one, and Lindsay might have a different one, is that, this is really looking at, can claims data be effectively used for clinical purposes? Where I think it's less contentious, at least in my opinion, for the committee would be, hey, we want to integrate these data sets for policy. And what I mean by that is it's in another domain, but say, for instance, working with the housing authority in Cambridge, we were like, oh, there are not enough affordable rental units in Cambridge, so people are moving outside. And practically what this means is that you can't use outreach activities for your economic development things to a local area. Like you actually have to, if you want to be serving your tenants who get housing vouchers, you have to be going to the folks in Malden and these Everett, because that's where your folks live who participate in that program. So I think things like that would be relatively uncontentious. I think where we're apt to run into concerns is with this, using it at a provider would actually see it and make clinical decisions. And so I think we don't have the evidence to show that that would benefit Vermonters and that can be done safely. So I think we want to wait for that experiment to happen. And then if AHS can make its case to a committee that, hey, here's good evidence, I think folks would listen to that and weigh the pros and cons.
Thanks.
Yep.
Leslie?
So I really appreciate the data nerds and doing all the work that you're doing. As a clinician, I got nervous.
Yeah.
Because who's in the room representing that voice? And that other end of the use of these data sets. So that's my curiosity.
I mean, I imagine that it's part of, if this experiment, and Will would know the contours of it better, would be like, not only is it beneficial to patients, but can it be delivered in an effective managed way to clinicians?
That would be after it's built. Sorry.
That would be after it's built. Well, that would be at the point where we were deciding to proceed and how we're presenting this information about the linkages. So I don't think we can, whether the end user is a clinician or it's a state, like you can't ignore the feelings of your population of actual users, right? And if you at least from my view, like one of the lessons learned from the OneCare experiment was that data presentations were, certain people could ingest them, but at some of the more rural hospitals, it was really problematic, especially when you didn't have data people on staff to kind of to make sense of that, right? So you always want to be thinking about like, who is the person who's going to be using this information, and how can I package it so it's persuasive and it's useful and it accomplishes the end which I care about. And that's, I think that's a common practice in computer science and probably should be a common practice in data for public purposes more generally.
Thank you. Daisy has a question.
I'm really interested in the fact that you're calling this an experiment, because it implies that we're doing something cutting edge, which sounds very exciting and sexy to me. So I want to dig in on that. Do you think that we're the first state that's doing something like this? Or that is doing this?
We're one of the first states. And I think, to me, given the potential risks to patient safety, say if we use it for a clinician to use the data, we want to be super sure. Like, I would need to see a lot of evidence that it can be done safely and it benefits the patient, just because of the risks. But I do think this kind of using administrative data and linking claims in clinical, like this is the direction things are going. We are not late to the game on this. This is kind of the move where things are heading.
I don't know. I would argue that we are late to the game, because I worked for an organization 10 years ago that was doing this with payer data and clinical data. And so I sent, I can send it to your office too, but I would encourage you all to look at it, because it's, I listed 5 other states when Lindsay was up that are already doing this, and they have great outcomes, and they're doing that at both the site level as well as across, statewide, those 5 different states. So I do feel like we're late to the game, and I am all on board with having this kind of tool in Vermont. I'm enthusiastically on board for it, and also appreciative of your diligence with regard to patient safety.
Yeah, and I mean, I agree, and definitely there are, pockets, especially around particular data sets. And I guess just in context, like I'm not saying it hasn't been done effectively, but 5 states is what? That's 10%.
That was 10 years ago.
That was 10 years ago, but it honestly not. I mean, we've fallen behind about the APCD, the All Payer Claims Database. When we instituted it, it was cutting edge, and subsequent to that, other states have caught up and far surpassed us. And the question is like, can we make something that works for AHS, for patients, for the Green Mountain Care Board? I honestly don't know, but this is like, hey, we're trying it out, and if it can be done safely to a benefit, I'm all for it. Not all for it if it can't be done safely. But we have the information already.
Robert, did you have a question?
No.
Okay. Thank you. Thank you, Eric. Sam.
Thank you.
And last but not least, certainly, we have Beth from Vital.
Hi.
Can you hear me okay? Yes. I hope you've been able to listen to the conversation.
I have. Thank you for including me. Shall I get right into it?
Yeah, go ahead.
Great. Thank you. I'm Beth Anderson. I'm the president and CEO at Vital. We are the operators of Vermont Health Information Exchange. I know you all have heard from me a couple of times this year, so I will try to not repeat much of what you've heard from me before. just going to give quick context reminder what VITAL is now. We're the Health Information Exchange for the state. We were set up to collect data from providers across the state, delivering care to patients. Providers can be a very broad term. Kind of match, standardize, make that data available for other uses across the state. Things like point of care. So making sure providers have more complete patient records in front of them when they're providing care to patients at the time of the care delivery. But we also make that data available for many other purposes. It is used by the Blueprint for Health to inform the reporting that they do for their practices. It was used by OneCare to inform and feed some of the data that they provided to providers in their systems. It's used a lot in public health. And so, when we talk about and I'm trying to address some of the questions that have come up. When we talk about interoperability, the reason for the HIE is, we do have a lot of EHRs used, electronic health records, electronic medical records, other types of systems capturing health data about patients that don't always talk to one another. And that's what we do. We have a team who works with the individual organizations to help make their data more comparable to the data coming from other organizations. So patient records really are a single usable record on the patient. So you have a complete history. I think what we're talking about here today is really expanding some of the work we do. So we have been making this data available for a lot of these purposes to date, but there's more opportunities, or there's opportunities to do more with the data we have in the Health Information Exchange, and then to get additional data sets incorporated into some of the work that we do to make it even more informative for all of these different purposes. Again, not just the point of care, though that is a very important piece of the work that we do, but these other sets, right? And thinking about how you do more analytics. And it is happening in other states with HIEs and other areas where they're delivering things like risk stratification on patient populations to help practices understand where they're doing well, where they're not doing well. It can be used on a patient-by-patient basis to identify gaps in care, right? And so that's where we talk about the value of like a unified health data space and what more analytics might be able to do, things that we hope to be able to do more of with these new capabilities. And we hear from practices all the time and providers and hospitals of some of the needs that they have. We're also going out and asking them questions. What is the information you want? How could you use this data? What data is helpful? And we're not just talking to the individuals or the groups providing patient care, but we're also talking to like the health information management teams and organizations and others, care coordinators, to make sure we're looking at needs kind of across the spectrum of healthcare delivery, not, I don't mean to minimize it, but not solely the providers, which are obviously, again, an important piece of our work. And so I wanted to just maybe comment on a couple of pieces within this section 10 of the bill. Overall, VITAL is supportive of the intents of the section. I think, regarding subsection B4 and some of the comments that have been made, particularly with Eric just before me, right, I think the integration of expanded types of data to better inform care, direct care, population health, public health is really important to the work. And it's about the social determinants of health data, the Part 2 data, the claims data. And some of it we know is useful. Some of it we're getting now, we want to do more of. We get social determinants of health data now. We want to get more of that in the HIE. Claims, as Eric mentioned, we're still exploring if there's value there, but we want to be able to deliver kind of tools and resources and information to the healthcare system that is what they need. And so I think being able to do some of these pilots and learn and grow and talk to providers and practices about what they want is really important work to continue. Looking at subsection D, and this came up a little bit in the discussion, is it's the language around ensuring the data sets are used for permitted uses. I think as we're talking about incorporating different types of data, it's really important to the work that we do. There's HIPAA kind of as a guiding foundation across much of this data, but different data sets are going to have different standards about how they can be used. And some were mentioned already, but at VITAL, the data that we have in the HIE, our agreements with the practices and the hospitals that provide that data to us, we limit how that data can be used. So it's not the kind of full spectrum of what HIPAA allows for health data. It's more minimal. And part of that reason is because we want to make sure the data that providers submit is not used against them or their patients. And so we don't use it, we don't allow it to be used for evaluation of providers' individual practices that could be used to harm the provider or evaluate them and limit their ability to give services. We think that's really important because we don't require providers to participate in the HIE. We want them to want to share and participate in the HIE and submit data. So we want the uses to be for the value of patients and their delivery of care. And so I think just something we really want to pay attention to. I know there was a bit earlier, a little bit of a discussion on patient consent. That's something that we take really seriously. You've heard me talk about this at Vital now, making sure patients understand how their data is or can be used, the data that we have in the HIE, and giving them a choice of whether they want their data to be shared. I think as we think about, incorporating these new types of data and having these new purposes for how the data might be used, we're going to need to be really careful at that and really thoughtful about making sure that we are doing more public education so individuals understand how their data is used, where it's housed, who might have access to it, what their options are for sharing it. That's something we really, really do consider at the core of our work and would want to make sure we are really thoughtful and careful about as we go forward with some of this work. And then finally, I think the last comment I have is just I really want to make sure that we are encouraging as we're thinking about integrating these data sets and delivering new services, that we're really making sure that we're reusing existing infrastructure and data sets and resources that we have, that we're not reinventing the wheel, that we're not creating new areas where the data is housed, but that we're being really thoughtful about what already are we collecting, how can we do a better job of collecting it and integrating it so we're not creating new burdens or different burdens on costs or somebody having to submit data to different locations. And I think the language covers that. I just think it's a really important piece of this work that we should be mindful of. So those are the biggest comments I have, but I'm ready and happy to answer any questions you might have.
Does anyone have any questions? I think I would ask you the same question that I had asked Will, which is absent section 10, if it was not here, is there anything that precludes you from doing this already?
I think give the same answer. I don't think there is. We had the work around the unified health data space and thinking about the analytics and more reporting for providers is work that's been in the HIE strategic plan for a while now. So I don't think that precludes it. There have been discussions about claims, clinical potential there. I don't think there's anything that prevents us from doing this work without it being in here. And I do think it's work that we have wanted to do and had on our kind of roadmap to do regardless.
Leslie?
Well, the inverse is, does this language help you move it along? So without it, or with it, makes it a better product?
That is a great question. I think having it's always nice to have kind of the support and the goals outlined in a shared document. I think it's also even having the language in here to talk has gotten the parties involved in some of this work, as you've seen even coming into the room today, to really have some good conversations about the directions we want to go forward. So I think it has absolutely been helpful in that way.
Thank you. Question, Woody?
Yes, I'm curious, what's the cost of all of this?
To deliver a unified health data space, that is a great question, and I wish I had an answer for. We are still in very early stages of really exploring what we might want it to be and look like. I know there have been some questions about understanding or asking providers what they want. Like we have some work to do to really define what we want this system to look like. And also I think phasing it out, right? Building, like knowing where we want to go first, where we want to go next, and testing it and building it. So I don't have an answer to give you right now on what it is to build. I think that's something we are working towards in some of the work to kind of design it and get and understand the needs that we're trying to meet. I think our goals here are not to build a monolithic system day one, right? It is trying to understand the needs, prioritize what those needs are, and kind of build and grow as we see the value and can come up with new use cases and needs for it.
Not even an inkling of what maybe would be the estimate? Or what is New York, what did it cost New York to do its this stuff.
Because New York is like a million times.
Yeah, I know.
Well, it's hard to compare us to other states, given our scale and scope. I'm going to defer, I know this is an easy answer, but defer the question to AHS, because this is really an initiative coming through the HIE steering committee. I
Are
don't
we
know
talking
that.
millions?
I'm sorry?
Are we talking millions here?
It's hard for me to say, right, what it would take. You know, there's the building a system and operating it long term. So do I think it's millions to build? Probably not, depending on, again, how we scope it and what it looks like in the beginning. But there is going to be ongoing costs to have a system like this continue to be available for providers and to deliver not just the system and the data and the capabilities, but also the education and training some of them might need to be able to really use the system within their work and help to improve their work.
Thank you.
The information currently in Vital, if it's used, so that's clinical information. If it's used by anyone other than another healthcare provider, is it de-identified?
So under HIPAA and our agreements with the providers that submitted, it can be used for treatment, payment, and healthcare operations purposes. And we do limit, as I was mentioning, some of the payment operations again, so it can't be used to like not give an individual insurance, things like that. So provider is a little broad. So it could be used by a care coordinator at a payer. It could be used by someone thinking about considering prior authorization approvals at a payer. It can be used by administrative staff at a hospital when the data is useful to support their healthcare operations capabilities. So any of that is covered under our agreements and doesn't require anything, us like limiting limiting the PHI to be de-identified. We are actually working right now with the Department of Health on a pilot of providing de-identified data to support some of their work. Now, they don't necessarily have to have de-identified data, but it allows them to more broadly share some of their data when it is de-identified and aggregated. So it's something we're practicing now. We're hoping to be able to do more of that for different needs, things like research in the future. But for right now, the organizations that we do work through the individuals who have access to the data. They would have full authority to have the data they have access to under HIPAA and our agreements.
Thank you. Any other topper?
Yeah, yes. Thank you for being here. I need some clarification in terms of at least the first comment that you have. You have 3 items that you want us to look at. And the first one is about goals and having clear, defined goals. Am I to assume that the way it is written now, there aren't goals? And also there's a whole list of things that need to be done to satisfy what I thought was the goal in the first paragraph. And that was to reduce administrative burdens on the providers and make sure that relevant information is available to patients, providers, etc.
Yeah, no, I'm sorry, I did not mean to imply that that wasn't a good and the right goal. My mention of goals and use cases is more where we've been talking about how the providers want to use the data. What will be useful for them to have that will achieve that goal, and what should the system be able to deliver? So that is more where I was talking about, where my comment was implying goals.
Okay, and that brings me to the point of all of those, the agencies process shall, and then it lists all kinds of things like identifying maybe a person's particular problem, maybe they have some underlying problems, identifying them so that they're safe.
Yeah.
Now that's in there. You know, develop and implement a system that ensures rapid access to patients, providers, and payers. What else? What what I'm trying to figure out is, what do you think we need to do other than what's there to make
I
this thing work?
Yep, I don't think I would be advocating for a change in the language that's in 126 now. I think the work that AHS and the HIE steering committee would do would be going levels deeper about what the real goals of this system are. So at a high level, it is about reducing burden, saving dollars and resources. But how we deliver that and what questions we're answering for providers for them to be able to be more efficient and effective. So that's where I think the work would happen more through the steering committee. Am I not understanding your question? I apologize if that's the
No, you
case.
are. I just think it's there already, that's all.
Any other questions? Are you all set, Tucker?
Well,
Or
I know this is a valuable resource that we have here, and I'm having trouble understanding what she wants us to do.
I'm not asking for change. I'm advocating for, I know there are some changes that the AHS, the Healthcare Advocate, and Green Mountain Care Board are proposing, which I'm in support of. But I'm not asking for specific changes. I'm supportive of the work.
okay. All right.
Thank you.
Thank you. Thank you, Beth, for joining us.
Thank you.
And I think we're all set for today.